Time being 8:15, the House Human Services Finance and Policy Committee will come to order. We do have a quorum, and Representative Jacobs moves approval of the minutes from Tuesday, March 10th, 2026. Are there any additions, corrections, or changes to be made to the minutes? Seeing none, all those in favor of adoption of the minutes signify by saying aye. Aye. Opposed, same sign. The motion is adopted, and the minutes are approved from Tuesday, March 10th, 2026. First on the agenda for today is an overview of the budget forecast that we received almost 2 weeks ago now. And so we'll call forward Director Bailey from the Department of Human Services to present on the budget and forecast implications. Technology usually works really well if you've got 15 people watching you, so.
Yeah, that's what I'm
proceed.
feeling. Let's see, it's gonna work. It's on our screen here, I don't know. There. Okay.
All right, well, welcome to the committee. Director Bailey, please introduce yourself for the record and present your testimony.
Well, thank you for having me, Chair Schomaker and members of the committee. My name is Elise Bailey. I'm the Budget Director for the Department of Human Services. Today, I'm going to just give a brief snapshot of the budget at DHS. And I know, Chair Schomaker, you asked for the February forecast, but I'm starting a little bit with the November forecast because there were a lot of big changes that we released in December that the February forecast builds off of. And so I'll just quickly go over kind of the highlights. So digging into our budget as a whole, just a reminder. So for fiscal year 26, the fiscal year we're currently in, DHS has a projected budget of about $28 billion. About 54% of that is from federal funding, $15 billion, and the general fund, to which most of the bills that pass through your committee are utilized at DHS, our budget is about $10.6 billion. The Healthcare Access Fund funds the Minnesota Care Program mostly, and that funding at our agency is about $1.3 billion. And then we have a smattering of other funds such as the Opioid Epidemic Response Account. We have some special revenue funds where we're taking in fees, and those fees fund some of the FTE costs, for example, for licensing. So a total about $28 billion in this fiscal year. So in looking at how our budget is spent, about 95% of that is on forecasted programs that I'll go over today in terms of the changes that we're seeing. Those include, of course, MA or Medicaid, our Minnesota Care Program, the Behavioral Health Fund, which funds mental health and substance use services along with some room and board costs in there. We have the Minnesota Supplemental Aid Program that assists older adults, general assistance, and housing support. 3% of our budget right now is spent on grants. So that includes the federal funds and the state funds. So pretty small portion of our budget is spent on grants. And then depending on the fiscal year, our admin budget is around 2 to 3%. So this is all of the systems, MMIS, SSIS, MAXIS, all of the systems that run eligibility and claims through our agency, as well as all the staffing. So that's a pretty small budget in comparison to the amount of work that the agency is doing. I would note too that we can't transfer funds between admin and the forecast programs, and so as our demand for programs goes up at DHS, the administrative costs do not. And so that's something just to note for the committee that has been a challenge at the agency and that we haven't kept pace with the demand for administering the program. Digging into MA or Medicaid, this slide just goes over the last, I'd say, 9 years since 2020. And some drivers of the growth here are we're serving more people. The average costs are going up over time, And that is the result of more people receiving HCBS and long-term care, as well as some increases, big increases in our managed care capitation payments that you'll see in the forecast in a little bit. I would also say growth is also with some changes that you all made in the last decade. A lot of them really good changes to serve people where they're at and making sure that we're meeting the needs of people. You'll see in the green bar, that's the federal share. So we get over 50% on MA from the feds, and that will vary by state. Minnesota has just about the minimum amount for our average federal match compared to other states. Some other states go all the way up to maybe even 70%, depending on their state's per capita income. And then a small amount of the Healthcare Access Fund does fund medical assistance. The next slide goes over the changes in the number of people that we're serving by eligibility category. So you can see in the red bar, the largest share of our medical assistance program is in the families with kids category. And then followed by the elderly and people with disabilities category and adults without kids. I would say in terms of total spend, the adults without children's category, as I went through with the HR1 changes, we get about a 90% match versus the other categories is largely around 50%. You'll see in the peak here in 2023, that was as the pandemic was winding down. And then we've seen it gradually drop as we went through the unwinding period and largely stabilizing in the out years. The next slide goes over our non-MA forecasted programs in terms of the funding source. In this fiscal year, we're projected to spend about $1.7 billion on these programs. You'll see the Minnesota Care program has a large share of federal funding that we get through the BHP, so we get about 95% of the tax credit that people would have received if they would have received health care on the marketplace. The Behavioral Health Fund also has a significant federal share along with the Alternative Care Program, but the Minnesota Housing Support, Minnesota Supplemental Aid, and General Assistance are all state-funded programs. And so that, of course, matters as there's changes in the forecast and changes in growth or decline in the people that we're serving there. Okay, so jumping into the November forecast, just a reminder on the numbers that we're looking at here. So the November forecast measures the difference between the end of session forecast, which is the February forecast of last year, plus all the things that you guys did and passed into law, all the fiscal notes. So that's the base, and then it measures to what our updated spending projections were this fall. We update our projections based on updated claims, so we're pulling in all of our updated data, how much we're spending, how many people we're serving. We also update the forecast based on what is known at the time of doing the forecast in terms of our timelines for implementing provisions or changes in implementation. And then in some instances, we have some federal changes that we incorporate into the forecast. So November was a really big forecast for us. I think probably the biggest I've seen in my tenure at DHS. In this biennium, in terms of the general fund, we had about 7.6% projected increase, $1.4 billion in state funds. And in the tails, about 6% or $1.3 billion. The Healthcare Access Fund also went up significantly, and while a smaller dollar amount, a bigger percentage. So about 11.5% in this biennium and 19% increase in the tails. A lot of that was the result of HR1 changes. So some key changes we saw in November, about I think 65% or 56%, sorry, I lost my notes, of the November forecast was the result of having to increase the managed care capitation payments. So about 80% of our spending on basic care, or 45% of the total MA program, is funded through managed care. And we fund that through paying the managed care organizations a capitated payment. So we pay them an average payment per person per month that is served through their organization. And then they're paying the claims on our behalf. Those capitation payments are required by CMS to be actuarially sound. So we hire an actuary who pulls in all the managed care data, and they reset those rates for us and have to certify that they're actuarially sound. Last year, we had to do 2 mid-year adjustments to ensure that those payments were actuarially sound, resulting in an average of about 16% increase in those managed care payments. This is not isolated to MA, I would say. When you look at CGIP or the marketplace, we're seeing similar trends in terms of average growth and healthcare premiums increase in this calendar year. When we kind of dug into why the increase is so dramatic compared to previous years, about 2/3 of it is the result of average utilization of claims, and about 1/3 is the result of the actual cost of services going up over time. One anomaly in that is pharmacy costs went up almost exclusively in terms of the cost of the drugs. Let's see. The next one I would that's a notable change in November is changes to the long-term care waivers. So we saw about, in this biennium, $306 million projected increase compared to what we had projected before, and $346 million in the tails. We've been in front of this committee several times going over the last several forecasts, and this area of spending always pops up. I would say what is different this time was that the DD waiver was the story versus in previous forecasts, it really was CADI that was growing at a rate higher than what we had previously projected. CADI is still growing. You'll see on the slide here about 1.7% growth in people and 1.6% in average payments. But DD notably went up higher than previously. So we're seeing the average amount we're spending per person per month go up. And the number of people we're serving, particularly with kids, go up compared to what we previously thought we would. Some other changes, about 14% of the change in the November forecast was also with fee-for-service. So where the previous slide was on the managed care payments, the other portfolio in MA is paid for via fee-for-service, where we don't use a managed care organization. We just pay the claims directly from our agency. And this went up due to just updated average payments per month per person that we're serving in the fee-for-service portion of the program. And those increases varied by eligibility group, just varying between 1% to 4%. We also were seeing increased number of people that we were serving compared to what the previous forecast was projecting. The forecast last February was really what we thought after the unwinding period in terms of where our enrollment landed after re-enrolling every person on the program. This November's forecast we would consider kind of the dust has settled. It was officially 1 year after the unwinding period had ended. And so we adjusted based on seeing that more people with disabilities maintain coverage on the program, about 5% higher than previously anticipated, as well as families with kids, and lower enrollment for older adults and adults without children. On the net, though, there was an increase in spending due to this, about $195 million in this biennium and $159 million in the tails. The next one is our general matching rate. So as I mentioned, we get around 50% generally, and that changes depending on eligibility category, but our general matching rate is around 50%. CMS does this analysis each year for each state, and they compare our per capita income to the average across the nation And then that percentage is modified. 50% is the minimum. So the state with the highest per capita income compared to the rest of the nation has around a 50% match compared to another state that may have a much lower per capita income. Their matching rate would be higher. So for our state this year, it went up a bit, meaning the growth of our per capita income was slightly lower than the rest of the nation, moving up just slightly to 51%. That means that the state share across the board is lower and the federal match is higher generally. I won't go into this slide in too much detail since I was already in front of this committee going over HR 1, but I would note this forecast has some items related to implementing HR 1 and some it does not. The items that are in the forecast include retroactive coverage. So the HR 1 says that states can no longer go back to 3 months, that they'll only pay for 2 months of retroactive coverage for most populations and 1 month of retroactive coverage for the adults without children population. Our state law says it goes back to 3 months, and so the forecast assumes that those incremental months that the feds will no longer pay for, that would be all state funds. Another item in HR 1 that is in the forecast is the provision related to people who are have lawful immigrant statuses. HR 1 modified who is eligible for the program and clarified that people that don't fall into the lawful, permanent residents and I think a few other categories would no longer be eligible for MA. In our forecast, we are assuming a reduction in the general fund, assuming that those folks would no longer have access to MA starting in October of this year. And there is a corresponding increase in the Healthcare Access Fund as a result of them then switching over to the Minnesota Care Program. The HR 1 also changed the federal match for the Emergency Medical Assistance Program. Prior to HR 1, we received the match according to the eligibility category that the person would have fallen into. So if they were in the Adults Without Kids category, we would have pulled down a 90% match. What this does is just in the background changes how much the feds will kick in for the same services, and it changes it to that general 50 or so % match that we would receive. Notably not in this forecast or even in the February forecast are the work requirements that we need to implement January 1st, 2027, as well as the cost sharing requirements that we're required to implement. Those items need state law changes, and so they were not included in the forecast. So jumping into February had, across the board, pretty small changes, very small, less than a 1% change. And almost all of it is within these 2 items that you see on the screen. First, we adjusted for enrollment. We saw with just the updated data between the data we used in the November forecast and the data we used in February, that we saw a slight increase in the number of older adults enrolling in the program and a slight decrease in adults without kids and families with children, resulting in a net reduction of about 29 million in this biennium and 41 in the tails. About 75% of the change in this forecast is the result of the prepayment review process, and there's 3 drivers related to that. First, of course, we started the prepayment review process in December, and that resulted in us, compared to previous forecasts, assuming that claims would be paid 2 weeks later than they would otherwise. And we assume that this is ongoing, that we would maintain this prepayment review process for the 14 services, and therefore, the first item here listed is just a timing delay of when we actually pay claims, just out 1 warrant cycle, a 2-week warrant cycle. That means that we're shifting about $53 million from this biennium into the next, and then the next biennium into the next. So it's just a one-time shift of about $53 million in this biennium that you'll see in the forecast. One other thing that we saw with the prepayment review process is that in the initial phase, we found that about 0.2% of claims were denied compared to the denial rate absent a prepayment review process. And so with this forecast, we're assuming that trend will continue with ongoing prepayment review. That's about $5 million in this biennium and $6 million in the tails. And then lastly, we did see about 4% fewer claims submitted during the prepayment review process compared to what had been submitted in previous warrant cycles. So we're assuming that ongoing with the prepayment review that trend would continue. And so that results in about $75 million in this biennium and $99 million in the tails. Some other smaller changes impacting the general fund. Well, this first one isn't a small change, but it's small in the expenditure forecast, the numbers I've been going over today. Last session, this body passed a nursing facility increase to their surcharge. And so we would take in more surcharges from the nursing homes, and then we had a corresponding add-on rate for the nursing homes that would net even to the nursing home, but pull in more federal funding. HR 1 clarified that states could not, or requires that states cannot add new taxes, essentially. And so this forecast assumes that those new surcharges that add to the surcharges and the corresponding rate add-on could only be effective through October 2026 is what the guidance we have from CMS states. That means that that add-on that we put onto the rates is assuming, we are assuming that that would be removed in October of this year, resulting in a reduction to the expenditure forecast. The revenue forecast that I haven't been going over today, I would note, also assumes that that surcharge is eliminated from the forecast starting in October. So that's the big cost here, about $44 million in this biennium and $118 million in the tails. We also adjusted the impact of retroactive eligibility. In the November forecast, we were pulling data from that was kind of muddied by the unwinding period, where people were re-enrolling and there was a lot of paperwork needs, and we did find that more people tapped into the 3 months and 2 months of retroactive eligibility, given all of the chaos in the system of trying to re-enroll everyone at that time, and that wasn't a typical utilization of retroactive eligibility. So this forecast, we're updating the data for newer data, and that brings down the impact of the state covering those incremental months. And then lastly, another notable change in this forecast is we're finding that we are serving more people on housing support compared to what we previously projected. However, we are also seeing lower payments per person. And so you'll see the impact here on the screen. And lastly, before I close, I would like to note some notable items that are not in this forecast. We have a lot of uncertainty on the federal level. And most of this uncertainty is not in our forecast for good reason. So as I noted, some HR 1 requirements are not in the forecast, and those will need to be passed in a bill. And so the cost of implementing those provisions and or the programmatic impacts of those provisions are not in this forecast, but they are significant. We also received notice from the federal government in January that they intend to withhold $515 million from the state in federal funding per quarter. And so that is not in this forecast. We are currently awaiting a hearing on it, and we don't have the timing or certainty enough to put it in the forecast. But of course, $515 million per quarter is about $2 billion a year. It will have a big impact if that actually comes to fruition in terms of the state budget. We also, another process that the feds are going down is the deferral. So where the withhold is saying, the feds are saying, we're going to withhold future money from you We also got a notice of deferral, which says we're going to take back money that we already paid for claims that you already completed. That notice was $259 million in one quarter. If that were every quarter, that would be another $1 billion that would present risk to the state budget. That is not in this forecast as well because we are undergoing a process with CMS on kind of digging into the thousands and thousands of claims that they're questioning. We anticipate that it will take several months before we know what the actual amount that they'll take back from the state. And then lastly, I would note we have a lot of extended delays from CMS approval of amendments and state plan amendments and waiver amendments from provisions that the legislature passed last year. The forecast does account for some updated timing in terms of, prior to the February forecast, we assumed a lot of these items that were supposed to be effective in January, we assumed, okay, maybe we'll get approval by March. And now it's past March 1st, and almost all of them we haven't got approval for. Some of the items can go back. A lot of the state plan amendments, such as the Nursing Home Workforce Standards Board rate increase, that's an estate plan amendment. We can do that retroactive. But the waiver amendments, say the savings items that you passed into law for disability waivers, we typically cannot go retroactive. And so that means there will be likely significant budget impacts to the state budget as the days go on, and we don't have federal approval for those items. And with that, I'll stand for questions.
Director Bailey, thank you for your presentation this morning and for this always insightful piece of our process here. Members will take questions now for Director Bailey. We have, I would say, about 15 minutes that we wanted to have for this. We have had, on some of the things that the director talked about this morning, we have had extensive discussions on already in committee, and so I asked them to prepare for the forecast today, which is what they did, so hopefully we can keep questions to that and not other proposals that may have come out in the last 24 hours or other things that are there, because they weren't asked to prepare for that for today. So we'll start with Representative Hicks.
Thank you, Chair. I have two questions. The first one is about federal approval of the waiver plan and the state plan, and then the other one is about admin. So maybe we can go back to the admin cost first, just so that we can get that out of the way, and then we can go to the actual impacts of some of the not getting the federal approval for the savings that we passed into law. So the 2% of budget operations not spent, you talked a little bit about that percentage. And last week we talked about grants and oversight and percentages, and there seemed to be, from the discussion, just not super clear on how that works. So could you walk me through, like, when we pass, for example, one of those grants and we include some staff in it, how does that roll into that admin, or is it part of the grants? Could you help us understand that a little bit better?
Director Bailey.
Chair Schomaker, Representative Hicks, thanks for asking that question. It's a key question. So when you have a bill for a grant, and we're fiscal noting that bill, we are simply looking at that grant and how much staff we need to implement that grant, or say it's in addition to a current grant. When we already have a deficit in terms of our base funding not sufficiently covering the administrative costs of the agency, we can't add that to your fiscal note. That wouldn't be fair to you all, right? We're just giving you the cost of one grant manager, for example. So it may be one FTE, or if it's a big grant, a few FTEs. Sometimes we include an additional oversight in our central grants office. But generally, we're not costing out needs that we already kind of had prior to that bill. We're just estimating the incremental impact of your bill. So I would say, to me, I try to point this out all session, because when you look at this graph, this is the programmatic costs of the MA program, and our admin has not gone up. And when we're, sending out more claims and we're doing more grants, if we don't have a mechanism to have the staffing appropriate to commensurate to the amount of, demand and work that we need to do to ensure program integrity, to ensure we have the systems that work behind the programs, to ensure that we have staff available to respond to grantees when they have questions. I think that's kind of key to the foundation of a lot of the challenges we've been talking about this session, is that the administrative costs have not kept pace with the demand for our programs. I would also say we've done a lot of analysis of, is this unusual to have a 2 to 3% budget? It is. Almost all other organizations could not operate on an administrative budget, including all of the systems we run, of 2 to 3%. So I do think it's something this committee should grapple with in terms of what is the sufficient level of resources that you need to arm not only our agency, it may, other agencies may be grappling with it too, to really, serve Minnesotans in the best way possible. So.
Representative Hicks.
Thank you for that explanation. I think I did not understand some of that prior to our meeting a few weeks ago when we talked about the grant piece, and so it's helpful for me to better understand it, because I did not, so I appreciate that. The other piece, you had mentioned the delays in CMS in both the state plan and the waiver plan for the things that we passed into law. And so we are at 90 days, I assume. Is that correct?
Director Bailey.
Chair Schomaker, Representative Hicks. So for the committee's knowledge, when we submit a waiver amendment or state plan, CMS has 90 days to approve or deny that request. In that time period, they can ask us questions, informal questions, and that time continues to tick on. But they can also request in a formal way answers to questions where they get to stop the clock. And they can do that once, and we have to hurry up and respond, right? And then once we've submitted the responses, that 90-day clock begins again. And so it could be, multiple months really for CMS to approve our waiver plan and amendments. We have several instances where we have the clock stopped. And we have other instances, because we have a lot of things in with them, other instances where we have informal requests where the clock is still ticking. So it really depends. I can get back to you on what items are currently stopped. And what items are currently on the clock. But a few of them are stopped, which is why we've been past the 90 days.
Representative Hicks.
Thank you. I really appreciate that. And if you could get me the items that are stopped versus what is in the 90 days, and ideally what the savings that we might lose look like. And this is really gritty in detail, so be like, no, Kim, I'm not doing that. But if I could get like the monthly impact so I can sort of see what that might look like for the budget, I'd really appreciate it, because we passed some significant, this committee did things that made my stomach hurt and made me nauseous and unwell, because we cut so many things. And if we aren't going to even see the savings from them because of these delays, I'd like to know how much money we're not going to save. Thank you.
Thank you, Representative Hicks. Representative Backer.
Thank you, Chair. And Director Bailey, my first question is which DHS programs, in light of what we've seen the last year and so forth, presents the greatest long-term stability challenges? With looking at the forecast growth, looking at the direction we're getting from the federal government, what stability problems are we seeing, or benefits? It could be something else. So if you could help address that.
Yeah.
Director Bailey.
Chair Schomaker, Representative Backer, thanks for that. That's an interesting question. I would say, just our long-term care in system in general, I'm concerned about not just from a financial perspective, looking at the costs, but we have a lot of challenges. We have growth in number of people that we do need to serve. We have the population aging, and we need an infrastructure where we are able to serve them sufficiently, while we have growing costs and the labor market is challenging for those long-term care facilities and HCBS providers to compete for labor in the market. And so the answer can't simply be, let's just cut all the rates, because we know that will impact care. So that's what I'm most worried about, where we have driving costs and driving, increasing demand, that we'll have to kind of think creatively over time how to best serve people to meet their needs with both of those drivers going up.
One more question.
Representative Becker.
Thank you, thank you. So what has been the strategy or the projected thought on how to control those growth, control that cost while sustaining services? And again, not just long-term care, it can be behavioral health, but what's the agency looking at down the road to be the best stewards of the taxpayers' dollars in providing those services?
Director Bailey.
Chair Schomaker, Representative Becker, I would say, making sure that the services that a person has access to meets their needs, that we're not serving we don't have care plans that are too much, where they're, from a labor perspective, we don't have enough labor for somebody who has lower needs to receive, a higher level of care. And somebody who has lower need or higher needs, making sure that they get services that adequately meet their needs, because there'll be cost growth somewhere else, and it's not good for them either, to be underserved. So I think the answer is multifaceted, though, making sure that eligibility for the program sufficiently has entry points that are standardized, and that, we're sufficiently have criteria that lets people into the program, making sure that when have care plans, that support plans, that those support plans meet each person's needs, and that the rates adequately match that. And then on the program integrity side, making sure that we're paying for services that are delivered. So I think it's multifaceted, and those are the aspects we're kind of looking at. The levers we have, right, are people that we're serving, services that we're providing, and then rates that we're paying. I think the solutions are really in all three of those levers.
Representative Becker.
No further questions. Thank you, Chair.
Thank you. Representative Gander.
Thank you, Mr. Chair. First of all, I want to thank you for bringing these data to life. I love spreadsheets, but if I look at the February 2026 forecast general fund base spending by budget activity, that's a lot of numbers, a lot of columns, a lot of different dates and trends to follow inside each category. So actually, of course, your presentation breaks it down wonderfully and brings it to life for us as policymakers now to try to interpret that information and guide our decisions forward. I also appreciate something you did not say, and the something you did not say was, based on these data, here's what you all should do, right? That's for us to decide, and I appreciate that you did not say that. So this was a very worthwhile presentation, given the information. I'm glad you actually went back to November to help us interpret the current update. My one question is, and you can sure respond to any part of it also, so as we think of providers now billing lower amounts, right? Some of them are billing lower amounts as part of the prepayment review process. Do we have an opportunity, maybe does the Optum Analytics have the ability to do kind of a look back on those providers and maybe evaluate some of the claims that they had submitted in maybe 1, 2, 3, 4, 5, 6 months, a year ago, to some way examine those claims for possible fraudulent activity, not making any assumptions, but just with that in mind. Thank you, Mr. Chair.
Director Bailey.
Chair Schomaker, Representative Gander, that's a great question. I will take that back. I'm not close enough to that process, but I will definitely take that back, because I like that suggestion. And we certainly have the data on how many claims that we've paid, of course. And so, yeah, that's a great suggestion.
Representative Gander.
I'm good. Thank you.
Before I go to Chair Knorr, are there any other questions? from the committee? Chair Orr.
Thank you, Mr. Chair. Thank you, Director Bailey. I think this is a useful information, but the key issue here missing is the HR1 changes that require a lot of quick systems fix, quick changes that we have to implement. If you quantify some of those changes that are necessary to be by January 1, 2027, do you anticipate that there'll be a shift in how much we're going to be spending to be aligned with the requirement under the work requirement, the frequent checks, administrative changes to the county, and whatnot? Do we have a plan on how much will that cost?
Director Bailey.
Chair Schomaker, Representative Noor, we do have a plan, and I'm hopeful to be in front of this committee soon with that plan. The governor, of course, will have a budget on that. I think within that, there'll be some policy decisions on whether, you want to implement them in full, or there's some items within HR1 that states can choose to how they implement. And so, of course, the cost will depend on that. But we will certainly be coming forward with what our proposed approach will be, and of course, the costs. I do anticipate a lot of administrative costs. One big item is the work requirements, and knowing that we can't just assume the counties take on all of the new work requirements, and then going from one time per year per person to 2 times per year per person. Counties don't have the workforce to take that on. So a lot of the administrative costs are strategies around assisting the local governments in doing that work. And then there'll, of course, be programmatic impacts. For example, we know a lot of people will seek an exemption, and that will result in folks changing eligibility categories. So we may get a 90% match for some folks. We would shift to a 50% match for others. On other parts of the forecast, we know that some people will simply lose coverage, so that would be reduced costs to the MA budget. So, yep, we'll definitely be coming forward with all those driving changes.
Chair Orr.
Thank you, Mr. Chair. Thank you, Director Bailey. I'm hoping that we're choosing the least restrictive options that we're given by the federal government, including the look back, ex parte, and many other options that are included in there, because we've been doing great and we're leading in terms of how we look and use existing data and everything else. So that will cost us a little bit, but also how we can support the counties. We did that during the unwinding, and we took some of the complex Medicaid processing to the state. I'm hoping that is the same type of changes that we will be seeing in the request that is coming from the governor's recommendation. So thank you so much, Mr. Chair.
Chair Schomaker.
Chair Orr. Director Bailey.
Representative Noor, we agree with you in terms of the look back period and making sure that we have the least restrictive, and essentially we want to have a system that mitigates impact to people, and that's a key decision point.
All right, Director Bailey, thank you for your time this morning. Next on the agenda is discussion of the budget impacts from 2025, and first will be testifiers from the long-term care imperative. As they're making their way forward, just a few editorial comments of my own. I know we're 2 weeks before deadline, and here we are having a whole hearing without one bill coming up. I have a dwindling soapbox, and this is one day to try and utilize that a little bit. As Representative Hicks already pointed out, last year we made some really difficult and gut-churning decisions in this committee, and now after the forecast, seeing what we have for the next year, we made those decisions to make next year easier, and boy, did we do it. And I think that a lot of that came from the decisions that were made from this committee, and particularly from the groups we're going to hear from today. It's not a comprehensive list of the people who are testifying today, and I understand that because the state plan amendments are still in review at CMS, that many of the things that we decided last year haven't gone totally into effect, but providers are still having to make decisions. on what they're doing. And so the request out to the groups that are testifying today wasn't so much to do advocacy as much as it was to say, to ask, what decisions are your providers having to make now, given the budget that was passed, and to get some more information that way, and to give half an hour, 45 minutes to the people who gave us the positive numbers, in my opinion, for the next budget cycle, so that we can all go back to the rest of our caucuses, and when they start talking about different spending initiatives because we have a surplus, or tax cuts because we have a surplus, that there were people who have paid a bit of a larger price for the numbers that we have today. And so with that, welcome to the committee. Please state your name for the record and present your testimony.
Thank you, Mr. Chair, members. My name is Kyle Burnt. I'm with Care Providers of Minnesota, here today on behalf of the Long-Term Care Imperative.
And I am Erin Hubert with Leading Age Minnesota, here on behalf of Long-Term Care Imperative. We will just be alternating back and forth for our presentation today, and happy to take any questions, Mr. Chair. Our focus today is really on three things: the state of the sector prior to 2025, to give us a sense of a baseline, the impact of the 2025 session on providers and the seniors that we're caring for, and then the things to resolve in 2026 or moving forward if we don't get to all of those things this session. So I think where we would like to start with all of you is that we were starting to see some really positive signs of pandemic recovery. Our workforce indicators were gradually rebounding, with vacancies down to the lowest level since the pandemic. We do still have about 11,000 statewide vacancies, but in my first year in this role, I was before this committee talking about nearly 20,000 vacancies. And there are a couple of reasons driving that decline, but it's still a sign of improvement. We are seeing agency use declining, which I think is a positive sign. So less use of pool and yes, less use of temporary staff. And we were starting to see some of those operating margins that the providers need to provide services, care for residents, pay wages, starting to rebound both for nursing homes and assisted living facilities. And then importantly, especially in light of 2023, all-time low in the last 5 years around providers who are considering needing to sell or close their building. So here are a little bit of detail about the vacancies and the key positions statewide. The graphs might be a little hard to read on the screen, but the key takeaway is really you're seeing an improvement year over year between 2022 and 2026. This data is from a survey of our collective associations of our members from around the very end of December to the beginning of January of 2026, and it is representative of the state. We do have it separated by position, so we have nursing assistants on the far left, LPNs in the second column, RNs in the third column, and dietary on the far right. I think this one's you.
So VBR, as you've probably had heard enough from us about this in the past, but reminder, it was adopted in 2016. Rate increases are now capped at the lesser of 4% or CPIU. Generally, we hear people say 4%, but of course it is 4% or CPIU, whichever's lower. VBR was designed to respond to the ongoing changes for the cost of caregivers and growing costs. The cap system, the way that it's going to be capped, removes this feature. It resembles kind of what we had before, which was a % increase each year and kind of falling behind on wages and falling behind on our workforce stuff. So, and one thing that we like to always point out and always reemphasize is we've been rate equalized since 1967. So what private pay pays is the same that public pay pays. So this slide is one that we really like to show off. This is when VBR was implemented. You see the big arrow pointing to the wage increases. So this chart is adjusted for inflation. So as you saw from 2001 to 2015, our CNAs got functionally less paid compared to inflation. And VBR worked to fight against inflation and increase wages over time for those workers. And then 2025 legislative session happened where we see that VBR was fundamentally broken in the way that it operated with the fluctuating rates that we had before now are capped into being what they are. Mandates and fees are contributing to a growing unaffordability problem. A lot of people are saying that it's too unaffordable in assisted living while we're adding additional regulations. And though the workforce situation is improving, part of the improvement is the fact that we have less beds, specifically in nursing facilities. We have less people that we're providing to, so the denominator has changed. And so we continue to have, it shows improvement, but the question is it really improving when we're serving less people? It's kind of just part of the math there. And we continue to have a big burnout problem with long-term care employees.
So Kyle touched on this a little bit in a previous slide. I think the impact of the 2025 legislative session, and in particular, the imposition of the cap on nursing facilities, is really going to be most felt in 2025 and to a certain degree, or excuse me, we're in 2026. Most felt in 2026 and then to a certain degree in 2027. And that is because most nursing facilities made really good faith investments in 2024 to increase wages, again, to try to restabilize our workforce, keep and retain staff, and fill those vacant positions. And so a few slides down will show you where some of these things have landed. But, you know, a facility who in 2024 increased wages by 10% would have that reflected in their cost report. That is now capped in their 2026 rate, presuming it is eventually approved by CMS. So, unfortunately, there are a number of individual nursing homes who are going to effectively see a cut this year. The minimum wage standards enacted by the Standards Board and then funded by the legislature in 2025 are now creating a wage compression issue as well within the sector. So individuals who either are being paid due to length of service or other factors within their particular care organization are now seeing those differentials flatten because the minimum wage mandate only gives a wage increase per position, not for things like length of service. And there isn't, due to the cap, the ability to move those things on our own.
So what we have in the next 3 slides are a few different aspects that we did. So I think that we should also remind everyone here that the data from this is from a survey of our members. So of course it is that from that angle, just to make sure everyone's aware that this isn't some other source. This is a survey of our members that we conducted earlier this year. So what you see on the slide here is over 70% of nursing facilities are forced to lower typical wage increases for staff that are not included in that were not increased due to the Nursing Home Workforce Standards Board minimum wage mandate. So you see across the board there, you see different regions, and then of course the statewide numbers on the far right. Might be a little hard to see if you're in the audience, but your package should probably have that in there. This next one here is a delay in investment in facility infrastructure. This is obviously a really important point as we continue to talk about making sure that this is available for years to come, as we know that there's a bigger generation of seniors coming through that will need this sort of access. So nursing facilities forced to delay infrastructure investments in many cases. And Mr. Chair, I'm sorry to report 93% of those in the southwest region of Minnesota reported that they are looking to delay investment in facility infrastructure.
So, Mr. Burnt, to that point, if you were, say, in a position in the State House and then decided to go back and work on your family business, expanding the business into nursing facility construction, probably not a good idea if you're from, say, the southwest state, hypothetically?
No comment, Mr. Chair.
Very well.
And then this slide here shows that reduction in non-staffing costs in areas of resident impact. 65% of Minnesota nursing facilities are preparing to reduce non-staffing costs. So some of those things might include staff training. It might be cable TV or streaming in the common areas. Might be some aspects of finding savings on nursing supplies. Programmatic changes, whether there's a bus rental to go to whatever local event there might be. Those are the sort of things that would fall under non-staffing costs that would be up for potential reduction. Not stating that any of those are specifically named by any facilities in this survey, but generally that's what they would look like.
As we shared over the last few years, I think what we're seeing in the survey of our members in 2026 is that the impact of the minimum wage mandate that applies regulatorily to nursing facilities is also having an impact across the care continuum. So over 70% of assisted living facilities are expecting an impact from those mandates in their particular setting type. 50% indicate that they will have to raise private pay rates in order to essentially compete with the wages and retain the workforce that they have as a result, an indirect result of those workforce mandates that are now applied to the nursing facilities. There is additionally another 22% that recognize that they're going to need to do something and they're just not sure yet what that's going to be. The next two slides are actually from a survey from the Minnesota Department of Health, and I think we wanted to provide them to you all today because it is, I think, reinforcing anecdotal information that we are hearing from our members. The first is the number of long-term care staff that have to do a clinical survey upon their attestation with the department that are planning to leave the profession in the next 5 years. And so we have drawn in particular a box around the numbers who are planning to leave among licensed nursing home administrators and licensed assisted living directors. So 50-ish% of both of those are planning to retire in the next 5 years. Another quarter-ish are planning to leave because they are burned out and dissatisfied with their job. So those are pretty compelling and striking numbers to us that we are trying to address on the workforce side. Additionally, what we found interesting is another question that that survey asks through the Department of Health is, what are some of the reasons that you're dissatisfied with your job? And one of the top responses is the paperwork demands are too high, which to us, again, points to the compounding impact of having to do more with less resource and on a faster timeline. And I think
so things to watch and resolve in 2026. Part of what we've already heard about today is DHS delays create uncertainty for residents, families, providers, and workers. Medicaid processing delays are reaching a breaking point with consequences for seniors and providers alike. And the final one on this slide here is the fiscal cliff for nursing homes are on the horizon. Reduction in revenue is almost $500 million is estimated through 2029 due to the 2025 legislative changes. So the pending state plan amendment, we obviously heard about this a little bit earlier today, and you've heard about it in the past. We're continuing to wait, and we're disappointed that the SBA was not submitted until after January 1st. That's, of course, created some resident confusion. So we've been giving a lot of notices to residents. So they would have gotten a November notice for their PDPM transition. They would have gotten a January 1st estimated, hey, here's what we think it's going to cost based on what we know. And then they will at some point get an updated one once the state plan amendment is approved, saying, here's how much it actually was supposed to be, and whether you get money back or you have to bill them for more. Again, this is for private pay. They are rate equalized. We are required to make sure that they are paying the same. So that does make it a little bit complicated, and it requires more conversations with families and residents to make sure that they understand why the billing is the way that it is. It does create that confusion. So this private pay estimating includes the granny tax and the CPI-U increases, and just the constant new rates that they're getting probably adds confusion to residents and their families. So implementation fallout. The state has provided a minimum wage rate add-on for in June 2025 with the funding. Without the planned state plan amendment, the legislation does not provide funding until 30 days after CMS approval. We are still uncertain when these funds will be available. Many of the providers that I've talked to, some of them have gone forward with the increases, and now we're paying for them without the rate add-on, which is causing some concerns for them. The 2025 minimum, as I just said, will expire as well. So we think about the expiration as kind of that fiscal cliff that I'd mentioned earlier on that three-pronged slide. That is something that we continue to monitor to see if we will be able to include these wage increases within the CPI-U cap when that rate add-on falls off. And that is a concern that we continue to monitor, and might be something we come back to the legislature on, depending on what we find.
So, Mr. Chair, members of the committee, the following slide represents some of the anecdotal data that we're getting from members on the impact of the 2025 session. Again, acknowledging without rate notices, without final implementation of the state plan amendment, these are their best attempts at approximating where they're going to land and some of the decisions that they have to make. It is everything from expecting about $163,000 to $164,000 a year in unreimbursed costs, of a loss of about $2.7 million across 2025 throughout a handful of rural communities in one of my members' sites. Another organization projects that they will lose about $1 million over 3 years. Another care center is projecting a pretty significant reduction in the per diem, and have started already reducing evening activities, which is one of the examples that Mr. Burton pointed to on a prior slide about how they're trying to meet the projected cap issues. I think the vast majority of our members anticipate, because of those good faith investments in '24, because costs were still relatively high, that they will be facing a cut this year as a result of the 2025 legislative session.
And Mr. Chair, I see that you're giving us the wrap it up look. It looks like we've gone to our times, but I will quickly go through these last couple slides. This one here is about county processing. Minnesota's application on average is taking 100.7 days to complete. The average longest outstanding application is 176.5 days. Federal standard is 45 days for the determination. What you see there is just a uninteractive version, of course, because it's just in this slide, but we also have an interactive version on our website, on the Long-Term Care Imperative website, where you can actually see each county and what the survey said for each county's specific number of days it's taking. We also included some county processing solutions in your packet. I will let you read those at some point. We'll hopefully have an opportunity to talk to the committee about that further in another time. But with that, Mr. Chair, thank you.
Mr. Burnt, Ms. Hubert, thank you for your presentation this morning. I think it was enlightening. Are there any questions for the testifiers? Representative Curran.
Thank you, Chair. I was just looking at one of the slides that says there's a reduction in revenue of almost $500 million estimated through 2029 from the 2025 legislative changes. Where did that figure come from?
Ms. Hubert.
Mr. Chair, Representative Curran, I believe it is a combination of both what the original fiscal note had projected in the tails, and then if you also factor in the match that our providers would be seeing from the federal share and then private pay, that number, essentially whatever the state share is, we end up seeing on the provider side times 3.
Representative Curran.
Thank you, Chair. Thank you. I'd love to get some more detail on that, just looking at the notes and the slides. It looks like the original figure included would have been $1 billion, and there's, looks like maybe a lack of clarity within the folks compiling this.
Yeah, I'm very aware.
And
Not one bit
just
happy
want to
about
make sure that we're getting some accurate data and not just putting numbers that sound big. Thank you.
Yes, and thank you to the Imperative for having such incredible transparency that you included the editing notes within your presentation this morning. Very deep regrets and apologies for that incredible mistake. But if you could answer Representative Curran's question.
Mr. Chair, Representative Curran, of course, we are happy to follow up with you. I think we also are gonna, number one, be embarrassed about the fact that you saw the comments notes and reflect that even as adults, we all have to do group work in real time, and what you are seeing was a product of some real-time group work while we were trying to resolve those numbers.
And Mr. Chair, if I could add to that too, I think that there was a miscommunication internally for those who were putting together the packet on that. They were using the numbers from the governor's original proposal last year and hadn't updated for whatever reason, and that's where we caught it, and that's why it's updated here, is that it wasn't caught in the first take on that. So apologies for that, of course.
Follow-up, Representative Curran. Representative Gander.
Thank you, Mr. Chair. You all are wonderful industry partners for us. We also look at a lot of the lobbyists who come here as continuing our education, right? We rely upon the information that you can share as we help to craft policy. So thanks for all of this. My one question for you is, as so deep as you are into the industry, at the end of the day, we want these businesses, organizations, nonprofits to be solvent, and I guess you could say profitable. So as our industry partners, and I know I'm putting you on the spot, but are there any regulations that we have in place that are unnecessary or onerous, that by revising those over-regulations, we can help these agencies, companies, nonprofits to be profitable or more solvent? Thank you.
Ms. Hubert.
Mr. Chair, Representative Gander, I'm sure our members would love to get you a laundry list. You know, the nursing home regulations are largely controlled by the federal government, which maybe limits our options. The assisted living regulations are certainly something we'd be happy to have a conversation about. I think when the law was enacted in 2019 for our assisted living communities, the goals around regulation were sound to provide safety, welfare for the residents, protection for the staff, et cetera. But I think we are starting to wonder if it isn't time to revisit some of those and ask whether we're getting value both for residents and for staff, because it is creating a burnout problem for our administrators, our nurses, and things like that.
Representative Gander.
Thank you, Mr. Chair. I would be glad to be part of that conversation. Honestly, if you want to direct any of these individuals toward me, and for sure we'll work as a team, but we would want to address those things because we know that drives up cost and drives up frustration. Thank you.
Thank you, Representative Gander. Representative Jacob.
Thank you, Chair Schumacher. So on the page where it says, according to MDH survey, reasons for leaving in 5 years by detailed profession. So, I mean, the graphs look very onerous, but it doesn't really explain to me. I think it says why the people who are asked would be leaving in the next 5 years. But do you know, like the question is, do you know what percentage total of people expect to retire in the next 5 years? This simply asked the people who are indicating that they're going to retire. Do we know what the total number of people expected to retire are, percentage-wise?
Ms. Hubert.
Mr. Chair, Representative Gander, I could ask MDH if they have information on the number who will actually retire. This was a survey that they fielded, so we're really limited today by what access to the data we had from their presentation, but happy to follow up.
Okay.
Representative Jacob.
Well, I mean, we don't know whether this block is 5% of the total amount of people working there or whether it represents 70% of the people, right?
Ms. Hubert.
Thank you, Mr. Chair, Representative Gander. It's my understanding that due to the way that this survey is constructed by the Department of Health, they achieve nearly 100% completion rate of those who are, a response rate. So they have pretty rich data that this is representative of the number of licensed administrators and directors.
Representative Jacob.
I don't think I asked that question correctly. I don't think I got the. I'll follow up later. Thank you.
Thank you, Representative Jacob. Final question, Representative Knorr.
Thank you, Mr. Chair. I'm looking at the county processing. I know that's a big question. You got the information based on doing your own survey, or did you get any data from the state or DHS or the counties?
Mr. Byrne.
Thank you, Mr. Chair. Mr. Chair, that information is entirely from our members. We did a similar survey last year, and I know that ultimately, I think that we had shared the Hennepin County information, and we were something like 4 days off, or 5 days off maybe, from what the actual county's version of the information was. Of course, this is very specific to long-term care. So we feel like it's a pretty good sample, generally speaking, and provides pretty accurate information, but of course is not the county's information.
Chair Noor.
Thank you, Mr. Chair, because we want to take a deep dive into different levels. Medicaid processing could be everybody who's applying versus only individuals who are 65 and above or who are in long-term care. So we want to make sure that the processing time reflects what the requirements are. I know there's also the SMART review process for other individuals, which can get complicated in that whole process. And given that we're going to be dealing with HR 1, and the look-back issue will come into play. So I'm hoping that we're all aligned in how we can get there. And then the other question that I have is about the delay in the SBA and the rate changes that are being paid. Will that be picked up by the VBR?
Ms. Hubert.
Mr. Chair and Representative Noor, I would believe ultimately it would be if it's approved.
Chair Noor.
Thank you, Mr. Chair. So is it going to be retro if employers have already increased the pay to the employees?
Ms. Hubert.
Mr. Chair and Representative Noor, we might need to follow up, but I believe the session law from last year was designed to be effective January 1. So I would, again, I would guess that yes.
Chair Noor.
I think Director Bailey may have a response to that question.
Welcome back, Director Bailey. Please help us with Chair Noor's question.
Thank you, Chair Schomaker, Representative Noor. I caught the tail end of the question. It's related to the Workforce Standards Board and the delay. Okay. If there is a delay, once we get approval, the rate increase will go back to January 1st. However, my understanding is that the requirement for the rate increase to go to the wages is effective 30 days, I believe, after the effective date is my understanding. And so there is a difference in the requirement for the employer to actually move that on to the workers.
Chair Noor.
One final question. So if employers choose to pay the higher rate and it goes back to January, that will be reimbursed based on the VBI process. Is that correct?
Director
Chair-
Bailey.
Chair Schomaker, Representative Noor, the nursing home will get the revenue from the increased rate. Yes.
Chair Noor.
Thank you, Mr. Chair. Thank you, Derek.
All right. Any final words from the imperative? Seeing none, the committee thanks you for your time this morning, and again, apologies for my error in judgment. Next, we have leaders from ARM to present on budget decision impacts from their perspective. Welcome to the committee. As you get settled in, please introduce yourself for the record and give us your presentation.
For the record, my name is Ken Bentz. I'm the Director of Research, Analysis, and Policy at ARM. ARM is a nonprofit association that represents over 200 home and community-based services providers. Thank you, Chairs Schumacher and Noor and committee members for the opportunity to speak to you about the impacts that cuts to disability services that were passed last session have had on the industry and the people that it supports. We appreciate this committee's ongoing commitment to upholding the dignity and humanity of people with disabilities. ARM has been working with legislators for many years to bring investments to disability waiver services in order to support people with disabilities and their staff. While investments by the legislature typically roll out over time, the providers of services make strategic decisions and invest resources in staffing and services. The situation flipped last session, and the legislature was faced with the unenviable task of cutting significant funding from this already vulnerable sector of our population. Unfortunately, cutting funding from a chronically underfunded industry has tragic consequences. You will hear specific examples and personal stories from the other testifiers here today. From the perspective of the trade association representing residential service providers, I would like to share several broader impacts that we are seeing across the industry. ARM's members are large and small service providers who offer an array of residential and wraparound services to people with disabilities, with very few of our members providing just one type of service. There is no one-size-fits-all approach when it comes to meeting the needs of people with disabilities. Historically, providers have responded to the dynamics of challenging investments from the state and increasing costs by suspending, or in some cases closing, programs and homes. The COVID years were especially stressful for our providers, and nearly half reported reducing their capacity in residential services in the years immediately following the pandemic. And even in our most recent survey, still about 1/3 reported reducing capacity in the past year, citing low reimbursements, future uncertainty, and staffing challenges as reasons. Future uncertainty has been a huge concern in the last couple of years and is especially acute this year with events over the past couple of months adding fuel to the fire. So what happens when the industry makes both short and long-term decisions on how to use expected resources and then has nearly $1 billion taken away before it even fully comes to fruition? Here are some illustrations. Last year, our members reported a turnover rate of 51.5% among direct support professionals in 2024. And yes, you heard that right, 51.5%. That's the highest rate that we've seen in at least 7 years. This indicates a very high level of churn in the direct support professionals' ranks, and in fact, over half of the DSPs who left in the first 6 months of their employment. When staff leave, they don't just leave because they want to. In many cases, they leave because they cannot afford to stay in the job. In our last member survey, providers reporting paying an average wage for direct support professionals of $18.36, which is below what is considered a livable wage in Minnesota. Unfortunately, the ability of the state and service providers to support the existing licensed capacity of waiver services is strained due to our chronic staffing shortages. Because 98% of our members' revenue is tied to Medicaid reimbursement, providers rely on the legislature to adjust rates in order to give their staff increased wages. Within the disability waiver rate system statute is a mechanism to update reimbursement rates and tie them to current economic conditions. Last session, the legislature changed the data that those adjustments are based on, moving from data determined by the Bureau of Labor Statistics to data from the Consumer Price Index. This change drastically lowered the rate adjustments providers would have seen this year or are expecting to see this year, reducing the revenue that they had available for staff wage increases, which they had already announced and in some cases implemented. Challenging decisions were also made last session that impact services provided to individuals in their own homes. Individuals living in their own homes are some of the most vulnerable to service disruptions. As opposed to a community residential setting or a group home, which is staffed to provide a 24-hour plan of care and is billed at a daily rate, services provided to individuals living independently are billed in 15-minute units. Some people receive a few hours of support a couple of times a week to ensure weekly tasks and goals are being met, but others may require a plan of care of up to 24 hours a day, every day, that allows them to maintain living in their own home. With a staffing crunch, individuals living in their own homes may find themselves going without services for multiple days if no one shows up to meet their needs. And there have been some tragic stories in the media of cases where support workers haven't shown up. You heard in this committee last week ARM's proposal to amend changes to the individualized home supports with training service. This service is critical for individuals living on their own to be able to maintain their own homes. During the 2025 legislative session, the number of hours of service an individual can receive was capped at 6, drastically reducing service hours for some individuals and jeopardizing services for some going forward. The fallback for individuals on a disability waiver who live in their own home may be moving into a community residential setting if there's one available. The recent announcement of a 2-year freeze on new 245D licensed providers and a freeze on current 245D providers from adding any new service line, both as anti-fraud measures, will make options for people seeking new services more limited. These options are especially strained in greater Minnesota. For example, 81% of all providers licensed to provide individualized home supports are located in the metro area. Similarly, with integrated community supports, which is a supportive service in a provider-controlled setting, there are 483 enrolled sites in the entire state, offered by 243 provider entities, and 87% of those settings are in the 7-county metro area. If an individual loses their provider, finding a replacement in the same community can be very difficult. Another decision that was made last session imposed new limitations on rate exceptions in residential services. As you may be aware, the DWRS statute includes a provision for a provider to request an exception in cases where the framework rate is not sufficient to provide the level of support an individual requires because of complex medical and/or behavioral needs. Several restrictions and administrative requirements were added to the process so that there would be fewer rate exceptions granted and they might be lower on average. One example is that providers can no longer ask for a higher daily rate for CRS residents to account for high numbers of days of absence from the home, even if known in advance. For example, to spend weekends with their family or to go with their family on an extended vacation. That leaves a provider holding an empty bed with no compensation for the days of absence. The change to the rate exception rules accounted for nearly $134 million of savings in the fiscal note from last session, and is another example of making cuts that threaten the supports for individuals with the most complex needs. In summary, for me, when legitimate providers close or cut back on their service offerings, people lose services that support them in maintaining their housing, stability, relationships, and trusted staff. We hope there's an opportunity to restore some of the investments that were cut last session and work towards bringing back some stability to services with people with disabilities. And with that, I will turn it over to the next testifier.
Welcome to the committee. Please state your name for the record and present your testimony.
Thanks so much. Good morning, Chair Schumacher, Representative Norn, representatives of the committee. For the record, my name is Tom Gillespie. I'm the president and CEO of Living Well Disability Services. We're a nonprofit service provider of residential and unit-based services. And we're based out of Mendota Heights, but we work across the entire metro, kind of out to Buffalo and all the way up in Cambridge. So kind of all throughout the metro as we would define it. I also serve as the treasurer for ARM, which is our trade organization. And as Ken outlined, the impact of the 2025 session cuts and discussion of future reductions on Living Well Disability Services has been extremely difficult, not just from the business and financial perspectives. I think those are the really predictable ones, but from a human and personal perspective as well. At Living Well and many organizations like us, we began last year with the intent, a stated intent, not a budget intent, not like a back room, don't say anything, a stated intent to our employees that based on what we believed to be true at the time, we would be increasing our wages from $17.50 to $18 an hour. And I hope we all agree that this is a group that's woefully underpaid, and that step from $17.50 to $18 is not wasteful spending or anything like that. This is critical. It's life-giving wages, and I know that doesn't sound like a ton. These are life-giving wages for people that without these wage supports cannot afford to do this work, as Ken mentioned. This increase, again, it was overdue for our folks and quite relevant, both for the organization to stay relevant in an employment market where you just heard Ken talk about an average rate of $18.36, but also, again, for the lives of our employees. However, as a result of the cuts that we saw last year, that came at the same time, to be clear, as an increase of tens of thousands of dollars in licensing fees. We had to walk back those stated increases. And later in the year, upon receiving a $500,000 increase for medical insurance for our organization, we had to go further backwards and reduce the amount of PTO that can be accrued by our employees, effectively reducing compensation in a year where we had stated budget support to increase our wages. So we didn't just stay flat, we took a step backwards. And we're not unique in our industry, we're not unique in that story. This impact obviously left our organization hurting, working hard to show our employees that we still value and admire their efforts. I think it's important for you to understand that nonprofits like us do not have stock dividends. We don't have bonus structures. We don't have things that keep our employees working for us like you might see in other areas of healthcare or other areas of business. We don't have those things. We have a mission, we have vision, and we have values. Those are the things that people connect to in our organizations. Those are the things that keep people in our industry, and they need compensation to be able to support that pursuit. They're not doing this work to get rich, $17.50 an hour. My admiration and the appreciation of this committee, and I know that you appreciate these folks as much as I do, it does not pay their bills. Neither does their strong desire to continue doing this work, nor the decades-long relationships that they have built. But unfortunately, we're seeing this desire and these decades-long relationships leave our field, and our employees, as they're leaving, at times with tears in their eyes, telling us that they can't afford to continue. I don't envy the challenges that lay ahead of this and many other committees. You face impossible tasks and you try to provision resources as best you can. I understand that not every need will be met. But I do need you to remember that unlike other groups or areas of your budget, in practice, we do not have guaranteed increases in all of our areas. We do not have automatic increases that keep pace with things like a $500,000 medical insurance increase in 1 year. We don't have those mechanisms. We have you. We have each one of you individually, and I hope you're hearing me right now. We have your action and we have your advocacy. That's what's keeping people in this business. That's what's keeping people supported. Please, please help us. To be sure, these impacts are not just felt by companies. And I realize that telling an organization story from a guy in a fancy tie is not what moves opinions in this state. There's a tremendous impact on families and individuals who are experiencing these cuts and trying to navigate this system right now. And to tell you more about that, my friend Doug is going to speak a bit.
Welcome to the committee. Please state your name for the record and present your testimony.
Good morning, Chair Schumacher. My name is Doug Abere, spelled A-B-E-R-E. I'm here today to represent our family with my wife Ann, daughter Jennifer, who is also a legal guardian for my 36-year-old daughter Allison. Allison is a developmentally disabled adult who requires a 24-hour plan of care with her in order to provide reasonable health and safety protections. She represents a common challenge for many families as we age and help each other on our life's journeys. We appreciate that Allison finds joy from being social and involved, that she continues to learn and develop. She wants to participate in many things, and she understands with a subtle anxiety always that she must have help to navigate through her life. For more than 15 years, her routine has included weekday transportation, activities, teamwork, and learning with peers at PROACT in Eagan. She also participates in recreational activities and in responsibilities and free time at home and in the community. In 2017, we purchased a modest townhome in Eagan, and we've worked hard to create a life for Allison that's as independent as possible. We did this partly because of the 2009 moratorium on adding licensed group home capacity now 17 years ago, and the practical impossibility of finding such placement. We also understand the original intent of the moratorium to encourage other more cost-effective home-based supports. Over time, we've partnered with Roommates for Allison and their families, case managers, service providers, individual staff, and many others. We navigated through the huge disruption of COVID and addressed challenges in arbitrary residential service program preferences that are often more costly and individualized or restrictive per person than seems logical. From the fall of 2023, Allison has lived with a special longtime friend and roommate. They love each other, and they're well aligned in their support needs. Our home service provider, Living Well, and others have worked with families to respect the rights of these two ladies and to share the lives that they want in the community. The best approach to serving the wishes and rights of these roommates has typically meant providing services on a 1-to-2 ratio of staff to those assisted. But let's be clear, the state's administration of individualized housing supports, or IHS, and similar programs has a significant bias toward a 1-to-1 ratio and separate programming for each person. There's a place for this, but the cost effectiveness of a 1-to-2 or 1-to-more home support must be acknowledged and better supported by coherent procedures and budgets. In current practice, in fact, IHS timekeeping is now on a 15-minute increment versus a daily rate for licensed group homes. I will conclude by representing the hundreds of Minnesota families like ours. We are hugely invested in helping you to provide cost-effective support for disabled persons in their homes. This is by rule. As Ken said earlier, these programs are among the most vulnerable right now. The proposed deep cutting now of support hours into little increments with bias toward individualized delivery truly threatens supports for disabled individuals to live their best lives. Such trends also significantly threaten coherent job placement for direct support professionals. Please continue your work this session to address these major threats. Please leverage the partnerships you already have toward high-quality, accountable, and cost-effective home supports. Thank you.
Thank you all for being here. Thank you for the work that you do. I'm really, really sorry. I'm really, really sorry. Because I've spent 20 years prior to being in this chair, coming up here and begging for minions, tiny little scraps, to just make sure that the folks taking care of people with disabilities could not end up on food support. Like, that was sort of where we were at. I distinctly remember working for a provider, working 35 hours a week, and working another full-time job. And while I worked at a provider where I cared for 4 people that I loved deeply, 3 siblings, in a very creative solution, I had a child with autism and complex medical needs, and we were paying our family health insurance out of that paycheck. So 2 full-time jobs, 75 hours a week. My take-home pay after my employer paid my health insurance was $235 a week, or biweekly. I made $500 a month in 2016 working full-time at a group home. $500. That's what I got paid a month. Because the health insurance was so high, and I needed the health insurance. Must have been 2015, because she was on the weird formula. So it wasn't the boy child, it was the girl child. And it was awful. And I did that work for 19 years. Your staff do amazing work. The people you care for deserve that kind of care. And we should be doing everything in our power to try to make sure that the cuts that we make in this state do not continuously fall on the backs of people with disabilities and seniors, as our previous presenters talked about. Because, as the chair so eloquently said, the forecast looks better because we cut people with disabilities, and we always do that. And so I want to say thank you for the work you're doing. I want to say I'm sorry for the work we did. And I want you to know that it does not reflect how valuable every single one of your team members is.
Thank you, Representative Hicks. And
Mr. Gillespie.
I'm sorry. Thank you, Representative Hicks. We are where we are, and I would still say we are here together. Let's do the next right thing.
Representative Hicks.
I'm sorry, I forgot to ask this. Just for clarification, do you have any other funding besides Medicaid?
Mr. Gillespie.
Thank you. We fundraise as best as we can, but that's the only other stream.
Thank you, Representative Hicks. Are there any other questions for the testifiers this morning? All right, seeing none. Chair Nor.
Mr. Chair, you already said the seeing none, so, but I just wanted to thank you for the work that you do. I think there's a lot of work coming, and unfortunately, with our budget targets and also the long-term group that is looking into the additional savings, yes, there'll be additional impact. I can let you know that. And also with the federal payment withhold and deferral, it's going to have an impact on all those services. So I'm hoping that by the end of session, we have got a clearer picture where we're headed, so there'll be more discussion on all of this. So thank you so much. Thank you, Mr. Chair.
Thank you, Mr. Chair. With that, the committee thanks you for your time this morning and for the work that you do outside of this room as well. Appreciate it. Thank you.
Thank you.
All right. And because those presentations took a little bit longer than we were planning for originally, and because we don't want to rush through the final piece on the revalidation update, we're going to move that to the agenda for next week and get that update at that point. And so with that, members, we all get to come back here at 8:15 tomorrow morning. And until then, we are adjourned.